Is 8:03 on May 2nd, Friday. And House Healthcare, we have a bill up for action today that came over from the Senate, S-27, and there is an amendment that the Senate made to our amendment. So we're going to hear from Jen, and then just take a quick straw poll on it.
Great. Good morning, Jen Carby from the Office of Legislative Counsel. Yes, we are talking about S-27, an act relating to medical debt relief and excluding medical debt from credit reports. And so I'm actually just going to put up put up briefly the House calendar, and then we will look at what you had sent over. So the House is proposing to concur in your House proposal of amendment with further proposal of amendment by striking out section 2, which had further amended the 2022 Budget Adjustment Act as amended by a couple of other acts since then. And so we'll look at what that language actually was, but for now, just know their proposal is to take that out and put in section 2 deleted in the bill. So now let me show you what section 2 is that they are proposing deleting, and this came up on the floor during second reading in the Senate. The chair of appropriations, Senate Appropriations, said, oh, hold on, I think we are doing something different with that larger appropriation that the bill was taking $1 million from. And so that section should not be, the moving the money piece should not be in the bill because we're dealing with that separately in the budget, but the $1 million is accounted for. So, all right, now I will need something different than this. See what happens when I put this. It's telling me one thing, it's showing me what I want. Okay, great. This is what the House had sent over. And so I didn't do a markup version because it's basically all the same. It keeps in the $1 million, keeps in the additional criteria and provisions you wanted added around providing information about financial assistance policies. But it would delete this section 2, which is reducing the amount of an appropriation that has changed a few times already to the Treasurer's Office for redeeming general obligation bonds prior to maturity. That based on what's happening in the budget, that 20 million is becoming something other than 19 million. So for us to put this in here and purport to be amending this particular appropriation in this way doesn't fit with the rest of the budget construct, but it's still, the budget construct includes the $1 million for S-127 that's appropriated in section 1. So from this committee policy standpoint, this amendment does nothing. From a budget committee standpoint, it's making sure that they're moving the money around in a way that's consistent with their larger work with this appropriation.
So the treasurer still has $20 million.
No, I don't know what the treasurer currently has or what the treasurer will have. What I know is that the treasurer will have $1 million to do this piece of work
Through the appropriation budget.
Yes, so some change to this 20 million is happening in the budget. But I believe they are changing it to a different number and moving other pieces of money around. So we shouldn't be in a policy bill moving money around in the budget. So this came from appropriations, Senate Appropriations, worked with Joint Fiscal on it, Emily Byrne from Joint Fiscal, and she said, oh, yes, this is what we need to do. So just striking that, moving the money around piece of the bill, which I think we had a bit of a heads up. Just where the money comes from. So you are still appropriating $1 million from the general fund to the treasurer. Your bill is no longer deciding where that 1 million comes from. But it is accounted for in the budget, I believe, in both House and Senate versions.
And just as a this may be referred to appropriations today, possibly.
I don't believe
not
referred to.
I don't think it'd be referred.
I think they may do the same thing you do.
Office.
Same thing you're doing right now, which is hear about it, take a straw poll on it.
Yeah.
But I would be surprised if it was actually referred there because that would suggest they wanted to make further changes to it.
Okay.
By having possession.
Okay. All right. So Any questions on it?
No
Right.
policy changes,
No
right?
policy
No
changes.
policy changes.
Not really any money changes from our standpoint. We already,
And I can't remember if it had been talked about in here, but I've been aware from the beginning that this existing potentially 20 million was sort of a moving target with other budget work that was happening. And so I'm not terribly surprised that it's either coming out or having further changes.
So we need a motion to,
no, we don't need a motion. It's a straw poll. All in favor of the Senate's proposal of amendment? It is, I can't, 902. 902.
Brian's on.
So, um,
901.
yeah, you get- Brian, did you wanna?
I support it.
Okay,
Yeah, I just hope that I just hope that appropriations in our body takes a quick look at it if that's the reason they changed it. So, you know,
I
if
hope
they
they do
change
too.
it to our jurisdiction, then I hope appropriations at least looks at it and does a straw poll. So
I am, I have been in communication with appropriations. And I believe that while I'm here in this committee, somebody is making these decisions and letting everybody know as quickly as possible. So, thank you. So,
1001.
1001. Excellent. All right. S 126.
Yes, one please.
Oh, look, I put 810 on the agenda and we made it.
Okay, so I believe we are up to section 8. Put the language up.
Yeah, that's fine.
Thinking about
what's
the
that?
All right, so we are up to section 8 on the statewide healthcare delivery plan. We walked through the language yesterday at the end of the day. What are people's thoughts?
What are people's thoughts?
I think the most input or requests that we had around this section came from BPQHC. But I think that beginning with their suggestions, which I support in full, might be a good starting point for us in terms of
Right, I'm gonna get out VPQHC's recommendations. It's white paper with their logo in the upper
blue, white and blue.
left corner.
Like
Left,
this.
yeah.
She's not helping.
Thingy.
Do you have it?
So, Daisy, do you wanna?
So I think just given VPQHC's charge with really supporting quality in healthcare and data analysis, their role in the state really speaks to the purpose of this section. And the bottom of page 1 on their written testimony really speaks to the intent of the language that they're suggesting. And the fact that they are really a independent, standalone organization speaks to their ability, I think, to really bring quality measurements to the data that we are pulling together in this bill.
Do you think, I don't mean to interrupt you, but you
Go ahead.
just say, do you think we should start with a statement of purpose
In this section? or
in this section? Is that not a good construct?
Don't,
Jen?
because
It's up to you. You certainly can.
I think we should pull in their suggested language and then maybe discuss it. Seeing how that changes it.
All right.
I mean. The language that they suggest, I'll say this, the language that they suggest. It pulls in some evaluation frameworks based on the RBA. Framework, which I think is powerful. That aligns with existing evaluation frameworks that AHS does, the how much, how well, and who's better off. So I think that's good because it could potentially continue some of the evaluations that we've been doing in the state, right? If you go look at the scorecards, that's how we already measure some of the healthcare progress in the state. And so I like that this is an idea that we hadn't yet really brought in depth into the bill. Yeah, I think there's a lot of power in bringing this language in. As far as adding a statement of purpose to this section, I don't know that it's needed, but maybe others do.
Okay. I just didn't know if something around being data informed. You had suggested some language. And
In section 1.
did we add that in section 1?
I sent that to you and Jen.
Right, I do think we had talked about maybe putting that in this section as opposed to section 1, because I think it's more about the goals or the direction that you're wanting the state to go as opposed to the purpose of the act itself.
Be fine with it.
Putting it in section 8 instead.
And making it part of the statement of purpose. I saw Lori,
I'm good.
I saw Mari, and then I saw Leslie.
I really strongly support this. And want to point out that the discipline of quality improvement, especially in healthcare, I mean, anywhere, but I'm more familiar with healthcare, is a really, it's a discipline on its own. It's something that people who have been trained, highly trained, and use standardized methodology. So it's not something that can be done easily just by a group of people that aren't trained in continuous quality improvement. So I think it's really important that we do, as part of our desire to have accountability and to be able to measure the effectiveness of this work, have professionals that are trained in this discipline. So I really like that, and I like that BBQHC is independent. And I like their language.
Okay, do they have specific suggestions on where language should be put?
They do. I'm in trouble with this.
Yeah, I'm not entirely clear where their first block of language would go. I think it may just be numbers to be added under the plan shall. But some of their language in numbers that they're proposing for number 6 doesn't necessarily fit with the identify lead in. So I think we would want to make, but I think, if you're liking the concepts, I think I can certainly work with this.
Leslie?
We received language on that same section 8, 9403A from Dr. Fisher. And I thought his language was clear and direct. I could read it or we could find it, whatever you would go.
Does it align almost with?
It does, because
Okay.
he took it, I think, further. It says agreement on care board in collaboration with AHS, DFR,
That was from an earlier version, just
from his notes.
That, yes, that's describing an earlier version where it was the Green Mountain Care Board in consultation with, now it's AHS. Just,
Okay, we reverse that. Okay,
that may be a topic of conversation for the committee as
yeah,
well.
okay, so let's say we had AHS first.
Yes.
And then all those other organizations, including VPQ, the Office of Healthcare Advocate, Healthcare Advisor, being established in this, and others shall establish an ongoing evaluation and planning process intended to address the immediate and longer-term challenges facing Vermont healthcare system and provide timely recommendations to relevant actors, not a word I would use, on how to address these as set forth in this section. I thought that was a clear summary and intent. So it sort of combined both.
Instead of what,
I'm not clear on the VPQ language, so
instead of what Daisy, me, and Hillary came up with, Jen.
I never saw that. I'm not sure is that.
She sent that to us. Daisy did.
I sent it to Mari, Jen, and Alyssa.
I didn't see it.
Yeah, yeah, it's not in yet.
I agree with where the conversation's going. I want to make sure that somewhere in here we have measurable,
Yeah.
as a word. And two, I also want to remind people, and maybe you got something from BPQHC, that at some point they said they would need an appropriation to do this work.
Yeah. So can we see that language if we're talking about it?
You have it. Can you pull it up, Jen?
Okay with your email being on the screen, or do you want me to copy and paste into a doc? I'll just copy,
I'm okay with the email being on the screen. That's a public email address.
just copy and paste it into a plain Word.
Where does that go?
Um,
5.
right, I think it was proposed first for one of the goals of the act, but I think it may make better long-term sense living in section 8 because it would be codified. So I think it would go on the list of the plan shall.
I agree, because it complements number 1 in the goals, improvements in health outcomes, quality of care, and regional access to services. This is kind of a more specified expansion on how we get to those things.
Are we gonna say anything in there about affordability?
This is just one, I think just
Just
one item.
We're not measuring quality, not affordability.
Okay.
And quality and effectiveness.
All right, so this should probably be in what the plan shall do. Does everybody like the language? I like the scientifically grounded methods. And the performance metric.
So is it, I'm still not clear where it sits.
Well, let's-
Does it promote accountability? Talk about, well, maybe we don't even need it because I think it's in there. The controlling of costs.
I think that's a different, I mean, there's a lot of,
Okay,
of purposes of the plan or requirements for the plan. This would be
Okay.
a requirement, but not the only requirement.
okay.
But yeah, because in number 4, it says the plan shall also establish targets for percentage of overall healthcare spending.
Okay.
If that's what you're thinking about, but it does refer to spending.
Just reading their stuff here again. Okay. let's put the language of 126 back up. Um, so let's somehow get to a point where we can combine the vision of VPQHC and what the plan shall do. Additionally, with the thoughts on Dr. Fisher, because I think these are kind of interwoven.
Let's integrate them, yeah.
And then let's make sure that we're have in here additionally anything that we feel as though these are missing. That's Eli, would you like to?
Yes, Eli Hogan, Agents of Independence Services. So we're excited to include VPQHC in this work. I do want to just remind the committee that VPQHC is a subcontractor of Rural Health Redesign Center, which within the advisory committee would be supervising the work of Rural Health Redesign Center, which then you couldn't be both the subcontractor and the supervisor of the work. And then for any work under the plan, you can't both design the plan work and then also bid on that work. And so we just want to be careful about making sure that the rules align with Bulletin 3.5, because these are statewide contracting procedures that are universal to all agencies and not something that Agency of Human Services can control. So I just want to make sure that when you're thinking about roles within this work, that you're aware of the limited roles that somebody can play.
Yep, Millen.
I was actually thinking, not to contradict that, in my head, I was thinking of VPQHC contract through the Vermont Care Board.
Yeah,
And not AHS.
Yeah.
Because they've had contracts before. I don't know what the rural subcontract that you are referring to, so I'm not familiar with that. So we just should make sure that there's no conflict there. But I would envision them being appropriated to the Vermont Care Board for contracting, not AHS.
And there is a section earlier where they're helping Fremont Care Board with other work.
So you're saying it's consistent with other things. If we went there, would there be a conflict with what you're saying then?
It would depend on the specific type of work.
Okay.
Go ahead. No, I was just gonna say, is the appropriation that we are contemplating wherever it goes right now, Green Mountain Care through whoever the contract goes through, has that already been accounted for in the ask,
No,
or is that additional?
well, so maybe.
Okay,
Oh, yay.
The answer is there's $500,000 for contract with the Vermont Care Board. DPQ has told me they need like 45 and 50,000. You could either add 50,000 to 500, or you could take it out of the 500 that's already sort of envisioned in the Senate contract.
okay. So the 500 to AHS,
No, 500 to the Vermont Care
to
Board.
Green Mountain Care Board in contracting, that contracting is envisioned for this purpose?
No,
I was thinking it was
No.
envisioned for
no, it's
the
other stuff.
reference-based pricing.
Have to be included.
You could either come out of the 500, so do 450 for the other contracting 50, or you could do 500 plus 50, do 550.
Or we could take money from the 2.25 million that AHS wants.
Yes. That was my
Or
next.
split difference or whatever, yeah. Yeah, it's only 50, well,
Yeah,
it's only 50,000, so
Yeah.
it seems like it'd be easy to find
okay,
within the money that's there.
because if AHS wanted 2.25 million
They
to
want,
do this statewide healthcare delivery plan, if they're contracting some of it out either through Green Mountain Care Board or through their own, whichever way it goes, then they wouldn't need that and we could move that money
to be clear, the AHS needs 4.5 million, we're splitting it up.
over 2 years. Yes.
Yeah, we took it out either.
Mari. Oh, Lori, was that what you wanted to?
No, I'm good.
just question for Green Mountain Care Board. And you can get back to us if you need to about what kinds of quality improvement processes the board uses now, or do you currently contract? Sounds like with VPQHC. I want to be sure we're not replacing or interfering with something that you're already, a methodology you already have.
Thank you for the record, Diane Langford, Vermont Care Board. I can see if we have any contracting with them, but I would stress that already in the contemplation, as I spoke yesterday, to the fact that as live things are happening in downstairs and probably in the committee conference for the budget, all of that work will impact particularly how this particular bill because of the resources that are in here. So keeping balance between them, if money is not included in the budget or starts to evaporate, which is already happening, less and less of already what's in here is going to have to come out, let alone adding more to it at this point. So you want to know about what is our contracting with them?
Or what other processes the board uses for continuous quality improvement, if even outside of contracting with someone else.
Nolan?
And just to add to what Diane said, Senate appropriation, if the money for this bill is in the appropriations bill, so it's gonna be within the context of that fund. So
Right.
you can have a memo or something to the appropriations committee saying this is what you need and hope that they give it to you. This will be dependent on that.
Your meeting today, Vermont.
Jessa? Jessa Varner, Vermont Medical Study, not relevant to the funding piece.
Do you want some money also?
No. If you're not finished with that, I'll put that conversation. I just had another piece to add on the report. Sorry.
Can we stay on the funding for a minute?
Yeah, let's stay on the funding.
Did Mari, someone over there.
Yeah, Mari, you had she was wanting to ask if you're not with their board.
Oh. But Nolan, you're saying that either way, the money for VPQHC to do this work is in the budget already.
No, I'm saying it hasn't been contemplated in the
Okay,
budget yet.
so we would need to write a memo.
I would think that past this bill, it's contingent on the funding. So the committee might think about it. I might suggest writing a memo saying this is what you need for the bill or communicating with your comprehensive committee.
Yes.
Because the House budget did not come.
Got it.
Well,
This bill's the next bill, so the budget just hadn't passed Senate.
Didn't it pass the Senate yesterday, their budget bill?
Their budget and include this money. But it's all up in the air with much very bigger today.
But you said we could suggest it come from the 2.2 that AHS was asking for.
I think that the conference committee House members are gonna be looking to you for guidance as to what you need for the bill.
Okay.
They're gonna negotiate it, they need to know what you need, and then they'll negotiate it.
Got it.
But I would recommend you break it out a little more specific, contracting for this and that, VPQ, where do you want it to come from, and that's what they'll look for. If I were on the committee, that's what I'd be looking for from them.
but in the way of a memo, not necessarily getting that granular in the bill itself.
I wouldn't, I mean, there's no appropriation in the bill already. I think if you write a memo or something to provide to them, it helps set the position, the House position on the bill. It might be.
Got it.
Eli, the $125,000 that AHS is asking for to support development of quality and access measures, targets, and monitoring strategies for a statewide population health plan. Who's that? Who's that for? Is that for AHS? Or is that to have a contractor?
That is definitely way above my pay grade. We can provide some information about how much these contracts cost, and do we have that, Nolan? Did AHS send the information about?
They told me how much we need in contracts, they didn't break it out. So. It was, for the record, I don't know if I said this yet, for the record, Nolan Langell, Joint Fiscal Office. It didn't actually say contracts, it just said Support feasibility analysis, 2.25. Then 125 to support development of quality and access measures, targets, that seems germane. To the BPQ, and to support development of hospital local budgets or other alternatives, that's another 100. So they didn't break it out any more granular than that.
Nolan, would you mind, what is the date of your most updated fiscal note?
April 24th.
Okay. Didn't we strike out the piece in the bill for AHS to support hospital global budgets for Medicaid?
Support hospital global budgets. I think we had that in there.
They have in their budget request $125,000 to support development of hospital global budgets or other alternative payment models for Medicaid. Didn't they doing that? They're doing that.
I mean, to the extent there's specific focus on global hospital budgets, I mean, it was more of Green Mountain Care Board, and you moved that to sort of reporting on feasibility and planning.
Okay.
Nobody is actively pursuing, in this bill, nobody is actively,
Developing anything.
you are not directing anyone to actively develop anything on global hospital budgets. You have,
Okay,
other than just the board as far as looking at feasibility.
okay. So there's 125,000.
I would have to work with HS, you know, they're gonna want to evaluate the current, say, what the numbers they gave me, or this is how much they need to do the Senate version. I want to hear from them on what they need to do the House version.
Okay, well,
Because this might, the other numbers might change too, the 2.25 could change. I don't know, I'm not them.
okay, I hope they're.
Right, and I think it will be hard to know before you have finished deciding what you want in the bill, what the various parties are gonna need in the way of.
But we could ask them very nicely to very vigorously and promptly respond to it.
Yes,
Yes.
to get more
Yeah.
information this afternoon and pass on.
That would be fantastic.
And I hope they're following along as we go section by section.
For here.
Yeah.
Okay. Okay, so we are asking VPQH in consultation with AHS. And it is envisioned that VPQH will be seen as a contractor and they will have a contract to do this collaboration. Or hold on,
Hold on,
please.
I'm not sure. So at the moment, I think there's, so far there's less in the bill about directing people to contract with other people. The bill itself has the agency in collaboration with others leading this work.
And VPQH is already in there, right?
VPQHC is being collaborated with in some form. But it's not, the bill as written does not contemplate that AHS is contracting out all of this work.
And they have a proposal for what needs to happen in the statewide healthcare delivery plan. And their proposal is basically saying, can you give us about $50,000 a year and we'll help achieve these? Is that what I'm
When you
getting?
say they, you're saying VPQ, not.
VPQHC.
I don't know if it's annualized. I would do it one time. And then. I don't know if you do one time or base. I don't know.
Sorry. Thank you, please.
Yep, so can I just make a suggestion?
Yes.
I think we should focus on what the language should be.
Yes.
And then we send it out once it's done to everyone to get the financial feedback. And then that will include how we do the contracting if we do it in language.
Let's talk about the language. Let's start with, do we want the Agency of Human Services to do this? We can start right in the, anyone have strong thoughts? Topper.
Maybe I'm on, but if the Agency of Human Services does this, then FQHC is there some kind of a conflict?
VPQHC.
VPQHC.
What?
Not necessarily, we just have to be careful that there doesn't become a conflict, so being careful about the scope. I'm watching that scope.
And I think we should just put in what we want and then,
Let them
let them.
figure things out.
Yep.
Okay. So Agency of Human Services, Leslie.
So Chris Collar gave us some testimony about where to house it.
Mhm.
And my notes, hopefully they're close to right. He thought it was good to distribute power. And that the power of rate setting is different from the power of monitoring. So since Green Mountain Care Board does the rate setting, and that's where that should sit, then the monitoring should be at AHS. That was from what I understood of his testimony.
I believe he also said that would be a possibility of being able to draw down a match.
That's right, that there was benefit there.
Whereas-
Exactly. Yeah,
Whereas with Green Mountain Care Board, it wouldn't.
wouldn't have that access.
Anyone else have thoughts?
I will tell you from the Senate side, it had started out, as I mentioned, with I believe AHS and the Green Mountain Care Board in collaboration with others, and there was strong interest in there being one party in charge, and I think there was general consensus that AHS was the right place for that.
Yeah. I just want to say I am fully in favor of it being housed in AHS as a distribution and a check on each other and working collaboratively with each other. I will say that one thing that I am really intent on putting in this section is expedient and measurable. And accountability. I want accountability that this is going to happen. As I've said all along, my frustration is I'm not sure I still see how this is any different than HRAP. And as Representative Donahue indicated yesterday, it was a great idea and it's never been followed through on. So the most important thing that I see in this is this will be followed and they will be held to account. I have Daisy and then Leslie.
I agree with Alyssa completely that AHS makes sense, and to me in large part because they have been doing similar work with those other plans. But my concerns are similar about us having a mechanism to hold them accountable. And I think with the addition of the new language, that one sentence that Jen brought up earlier, accountability is one of the first things that we name in it. But I think it's going to require work on our part of doing that work to hold them accountable. It's going to require us to actually read the reports that come in and take action on them, whether that means new legislation or just simple communication. And we have to improve our footwork to do that. And, we should be a collaborator either in an informal way or a formal way. And that's in terms of monitoring as well. But I think VPQHC plays a major role in that as well by providing measures and accountability measures as well that we can clearly interpret and that are easily publicly available so that we can have assistance in doing that.
Thank you, Daisy. Leslie?
It was really interesting that Representative Donahue was here and trying to understand about HRAP. And what I don't understand, and maybe someone can help me, is why it failed or failed. And want to not do the same thing again, to create a system that's not doable. So I'm not sure, maybe someone can help me, why HRAP never got implemented. Did it not?
I think it is implemented.
Yes, it is.
Well, okay, so that's what
We had testimony from AHS and they said that this is the work that they do every single day.
So Green Mountain Care Board has responsibility for the HRAP,
that's right.
not AHS.
That's right.
Yeah, that's right.
Oh, you're right. I'm sorry. It's the Office of Healthcare Reform that I was.
Yeah, and it hasn't been updated for a bit because we've been elsewhere, and I get that. So I'm just not sure what we need to do to make this solid, and that's what I want to do.
I think HRAP was more about having a sense of the lay of the land.
Yeah.
I don't know that it was, I'm trying to pull up the language, but I don't recall it being a particularly action-oriented.
So maybe that's the
document.
point, that HRAP was about resources and this plan is about delivery. And that's what we need to really focus on is delivery. And, and Representative Donahue talked about sunsetting HRAP, and maybe that would be a good thought as we move from from resources to delivery.
I think we need to understand HRAP before we.
That's what I'm saying. I don't think we understand it.
Lauren, can I make some suggestions on language so we move along? Because
Yes.
otherwise we're never gonna get stuff. So I think there seems to be general agreement, AHS should be doing it. I think we need to add in that language that Daisy and team came up with. I don't know where you think that would be appropriate.
Somewhere in the list in B of the plan.
The plan shall. I think if we put that in, we get to the chair's accountability and measurable aspect. I think we're gonna at some point get to where the reporting is back to everyone and we can beef that up if we need to. I do like the FPQHC's other line that says on A, identify or negatively impact quality, access, and affordability. So that's on under 6.
So my only concern with that one is just that I think, they could spend a whole year coming up with all kinds of circumstance, ideas for service closures or consolidations that would negatively impact quality. I think you can.
That's true. Okay.
That one's easy.
Okay.
It's the coming up with ones where it
Where
might
it's
be
not.
helpful. That's the hard work.
Yep. And then
The committee can have different thoughts, but when I read that, I just think like, well, I could list off, let's see, 14 hospitals, they could all be
Right.
closed. That would negatively.
Good
I
point.
don't know where you're talking about.
The bottom of VPQ proposed language,
Second page.
second page.
So then I'm also going to throw out, I liked Rep Donahue's, and I don't know how to do this, and I don't know if she sent language, call out challenges. I've got geographic, demographic status. So incorporating some of her stuff, and then my only other thing is I believe the title change. Statewide healthcare delivery strategic process.
So strategic.
Process or?
I don't like plan because a plan's gonna sit on a shelf. Like, is there another word we can use?
System.
Strategic.
I'm serious. Statewide healthcare delivery system.
Analysis?
A system is something that is created and is ever evolving. Or a statewide system of healthcare delivery.
Well, I think the system itself is the work that happens out in the field and delivering the care. I struggle to have them come up with if it's going to be a document, it's not a system.
Yeah.
If it's a delivery system, it wouldn't involve all the people.
Let's keep plan. I don't want to go down the rabbit hole.
Okay. But do people like strategic? That was a VPQ
Yeah.
recommendation. I thought that was nice. Anyway,
So there are my thoughts, and otherwise, I think it's great.
Strategic.
So I'm on the table.
Trying to find Representative Donahue's. Well, that's her other.
Is there anything in the current language that anyone would like to strike on what this plan will build upon and what the plan shall be?
I think I need to see it with the VPQ language added in and then come back.
I will say that in number 3, I do not like the word strive.
That was my effort to have something less than ensure that people said was unrealistic, but making it a priority. So totally open to other words. I think people who were downstairs may remember me trying to
We just
come up with synonyms.
sort of strive to and just say they shall make mental health services.
Well, I think that's the same issue with ensure, is that the plan can't necessarily make services. I mean, that's the goal.
Why can we not have a plan? Like, I would argue that we should have a plan to make those services available in every region. I don't care if it takes 10 years, but we should have a plan. There's no reason why we should not be planning 10 years out to have mental health services available in every region of our state.
I mean, this is just the plan shall. So the plan itself doesn't mean we've achieved everything in the plan. It just means that we're making a plan that has that.
Exactly.
So, I mean,
Right, I think
the
the
plan is
plan
aspirational.
And can plan to have services available, but a plan can't make them available. And so that's where I ended up with strive to, because I didn't want to say the plan shall plan to make. So again, if people have other words, happy to put them in. Or if you just want to say the plan shall make the services available, I can put that in. It won't
Where are you
happen.
looking? I'm sorry.
I think we should say, make them available.
Just make.
Yeah.
I think so too.
Just make them available. It's the plan.
But the plan isn't making anything. The plan is saying what should happen, and then other people have to make it happen.
Include mental health the plan shall include mental health services, substance use disorder treatment services.
Well, I think if we're gonna do anything substantive, we have to ensure that these three things are gonna take place.
But the plan doesn't allocate, doesn't make it happen. The plan says this is where it should happen, and then other people need to step in and make it happen.
Well, that's where the accountability comes.
Well, that's what I'm saying is though, if the plan, in this plan, it should have well thought out what the perfect allocation would be of mental health services, substance, SUD, and the other things for all regions.
They can't make it happen.
It's a grammatical thing.
Yeah.
Yeah, okay. Well, what's another word?
Include.
Include, that's exactly where I was.
But includes.
No, I don't want to say prioritize because there's other,
But we're going to prioritize
Make it.
everything.
We're talking about the plan.
Brian usually is looking at his thesaurus right now. So why can't it be combined with the one above it? Plan shall promote access to high quality, cost effective acute care, primary care, chronic care, long-term care, hospital-based, independent and community-based services, mental health services, substance use disorder treatment. So, I mean, why are we
Yeah.
separating those out?
We always silo mental health and substance.
So here she's trying not to. I didn't know if there was a reason.
Marie, I think that's a good idea to put them together. But what I'm worried about is the first word.
what about promote access to?
I hate promote.
Okay, well, then you hate number two.
I
Well,
think promotes fine, Topper.
I mean, we're saying promote
I
access
want to see
to,
action here.
how about just saying promote access to make mental health services, substance use, blah, 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 across all regions.
The plan shall provide a roadmap.
We use roadmap in statute? Can we use roadmap?
Say map.
You get the hint.
Thank you, Madam Chair. I'm sorry to interrupt. I appreciate this opportunity. So what is sitting here, Green Mountain Care Board, thinking is that there are many other places in this bill that instructs the Green Mountain Care Board to use this particular plan to evaluate things that are happening. And I just don't want that to get lost, that all of a sudden something should become out of a line. And that if we're going to look at someone's budget, the way that their hospital is run based on this plan, or any CON that comes before us that's based on this, evaluating it, weighing it against what comes out of here. I just want to be really careful that we don't, that piece is still aligned.
To your point though, is this is the plan that the Green Mountain Care Board will then have to follow in all sorts of other things that we've put in this bill. So if we task AHS with striving to make mental health services, blah, 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 AHS could very simply say, we strived, we couldn't do anything. And then a hospital comes before the board and they're like, we're gonna cut our mental health beds. And now the Green Mountain Care Board is in a position of saying, well, you know, it's not in the plan.
It's not aligning, your actions are not aligned. I don't even know where in the bill all of those little points are, I was just juggling it. Yeah.
You use the word provide.
Oh, okay, we're getting,
I like Lori's idea of combining them.
That's what I was raising my hand to
Yes,
say.
move it
Yeah,
into
move
two.
it into
Move
two,
two and
leave it
move three
promote.
into two.
That's commonly used language.
Mhm.
It's
can-
commonly used at AHS, I know, it's commonly
Yeah.
used through healthcare.
So that I can get on board. here.
Wait, hold on one second. I just want to clear the
Hold on.
language.
I'm holding on.
So independent, community-based services, we can, if we're doing that, we can cross out the across Vermont and then continue with the list and say accessible to all
Mhm.
regions of Vermont. Okay,
Which I
sorry,
think
Topper, go ahead.
you
I
can do
just wanted to get that
Okay.
got out.
Daisy, I want you to convince me that promote is an action word. I see somebody, when I hear that word, I hear somebody on a soapbox.
Yeah. Okay, so I think
As provide,
promote, if we go to like the VDH website or something, you'll see like healthcare promotion it means more than just to advertise something, right? You think about promotion as in like it's a coupon or something that's used to promote. That word's been borrowed by that industry, right? To promote something means to like encourage it. You can just encourage access to. It's a simple replacement, but if you work in health stuff, it's used everywhere. Go to the VDH website and look at it.
I was just gonna say,
Promotion is
I think Topper, to your point, like all the other stuff in this section leads to the action that you're looking for.
Yeah.
Right? So identifying the gaps to access, circumstances in which service would affect quality access, opportunity, like, I think the rest of it, this is just saying what it has to be in regards to the type of care.
let me just, I honestly believe if we don't take care of these three things that are listed here, this healthcare system is gonna be, it's gonna implode.
Any reasons?
So I just want to put so much emphasis on it that it actually happens.
Okay, I'm gonna let Leslie, and then we're moving on from this.
So someone mentioned that, Brian, so I looked up the word promote to help us understand that word, and it says further the progress of something, support or actively encourage, advance or raise to a higher level.
I have advanced.
Yeah, and so I think the idea is that it's a verb.
Yeah.
That is furthering the progress.
I think to Lori's point, that I think the action we're looking for is further down. So let's get to the action. So we're gonna combine those. And let's see, growth rates or annual targets of total cost of care. We kind of heard. We heard from various people about concerns about using this total cost of care and what it actually. It just lost George.
Yes, they're in the hallway.
Do we need them?
I thought that they had concerns about it. But maybe I'm not remembering. Um. Should the statewide healthcare delivery plan um, developed by AHS in collaboration with a bunch of other people. Should they be setting the annual targets for total cost of care, or should the board be setting that?
So the board's proposal would keep in the first part, provide annual targets for total cost of care across Vermont's healthcare system, but take out the rest of the sentence around reasonable annual cost growth rates and excluding certain types of revenue.
Yeah, I don't.
Period after growth
I
rates.
don't know if we do that now.
No, there's period after system on line 4.
Okay.
That's what the board's suggestion is. I
am inclined to. I mean, I don't understand why the statewide plan developed by the Agency of Human Services should have, you know, annual cost growth rate, why they would be even and contemplating how much should be hospital total cost of care. Why are,
AHS is leading the work. Various other parties are collaborated with, and there's direction for the board to specifically contribute certain data and expertise, including related to its regulatory duties. So it could be that that was if you're including that, that's a piece that the Green Mountain Care Board is the lead on.
yeah, and we've struck from the hospital budget over budget review process, the revenue derived from primary care. So I think we should strike it from here as well.
Do you want so the board would strike and include reasonable annual cost growth rates? Would you also strike that? So follow the board's
I would strike that.
recommendation. Okay with that?
Yes, thank you, Madam Chair. I'm aware of many of the list of things that the Green Mountain Care Board is currently already doing, so that is a part of what we do already. I'm not so sure and would like to check on the total cost of care. Coming up with that, I'm not 100% sure if that's something we currently are doing. And I think our attorney that was in here had recommendations around this.
Okay,
Right.
it's just that the statewide, again, the statewide plan being developed by AHS is going to set an annual target for total cost of care, which then the Green Mountain Care Board will have to adhere to in other things that they do.
I think it's just the suggested,
Okay.
the red line language is what they're
Okay.
taking.
So
Do you view this as them setting the annual targets or just?
I mean, they're
Providing-
providing what they should be. They're not enforceable unless and until somebody is directed to enforce total cost of care targets.
Okay, so let's take out those. Leslie, I see you. Hold on, please, though. Okay. I was just reading the rest of it, like the rest. Leslie, and then Daisy.
One of the things that Chris Kohler talked about was needing positive incentives in that section, and I'm not sure I necessarily understand what that would look like, but I thought it was an interesting idea. So maybe there is no such thing, I don't know. So if total cost of care goes down, you know, what do we get for it? But maybe that doesn't belong here. I was interested in that idea, but I don't know what it looks like.
Daisy?
I'm not sure I understand how, like, the relationship between setting this total cost of care and doing global budgets, or whether we're not doing global budgets. And since we're not setting Medicaid rates and what's going on with AHEAD, like, I just feel a little confused around how and if we can control the ability to set the total cost of care.
Well, I think it's their job to go and look at all the healthcare resources within the state. See where things should be, where things should not be, what is missing, what is maybe over. Coming up with a strategic plan. And I think that in that, there should be an affordability piece of what Vermonters can actually afford. And what are the resources that we have and how do we allocate those resources?
I think the idea behind the targets for total cost of care is to have the various stakeholder players who are involved in this contributing their, the information from their sectors to identify what is actually a reasonable total cost of care that should be what is aimed for.
How big is the pie? If you're gonna start allocating who's gonna have what size piece of the pie, first you gotta know the size of the pie.
Yes, and that sounds a lot like global budgets to me.
It sounds like
That's potentially a way of implementing or achieving the targets, but that's, I think, the next step. I think the first piece is just getting people's arms around what the total cost of care is and what the state's vision is for what it should be. And those are the targets.
So we can still do this as we are doing reference-based pricing.
I think, yeah, I think some of it will inform other aspects.
Got it this way, at the beginning of the year, I don't know if it's JFO or whoever the fiscal people are, they come in and they tell us what they anticipate the revenues of the state are going to be and how much we have to spend. And then we go to work and we allocate those resources. This is them coming in telling us how much is the budget, how much of what's your budget? And I mean, this is imperative, frankly. I think this is the most important thing to get right. And then this envisions how it's allocated. And I especially like the end. Because as we heard the other day, when you have 50% of the care being provided by 5% of the slice of the pie, that's where we need a reallocation. So can we move on from that?
So I think this is good language. I like it.
I like it. So this is just, this whole section is what we're building on.
Yes, this is recognizing all of the other plans
Yeah.
and estimates and planning requirements and assessments that already exist. Great.
Okay.
Yeah, question.
Yes, Tupper.
Jen, please help me on this. Does the definition of primary care, I just was trying to find the damn thing. Does it have mental health services, substance use disorders, and all the rest of that?
Depends.
Medical services?
Doesn't have emergency, I don't believe it has emergency medical services, but there's been a lot of work that has been done in the past. Stakeholders just trying to agree on a definition of primary care. So in this case, we're being clear that primary care, in this spending on primary care with the target, that would include mental health services. But we are not attempting to,
Daughter as well.
that is not specified in here as part of the target for percentage of overall healthcare spending that should reflect spending on primary care.
And I apologize to go back, but can we strike treatment services so that this also includes prevention?
Oh,
On line 7, I'm sorry.
You took that section out.
yeah, we took that.
Oh, right, okay.
I would like to add to the data and information that they have to look at. VMS's suggestion on the report regarding the total healthcare spending allocated to primary care as the Act 17 of 2019 blueprint for health on patient-centered matter. It's in their language.
Yes, I remember the report.
Yeah.
Okay.
I think Jess has submitted language, and I would like to ensure that that is. I agree.
In 4?
X or Z.
5, hold on data and information.
Yep.
Um, and I know I was listening this morning before committee to Representative Donahue's testimony that I was not able to be here for yesterday. I know she had suggested adding 9410 in here. That's V-Cures, and I'm not sure if that is specifically the name of it in statute doesn't necessarily tell you that it's V-Cures, but it's V-Cures. So I don't think that that fits in here. So I would suggest not adding that in unless you feel like that is something.
She had also recommended, she said that there were things in HRAP that were envisioned would be looked at that she didn't feel was in the statewide plan, and she'd like to move them into this. And would that be more along the visions that we already went through?
I don't know, I have to look back at it, but I made a note
Take a look.
at her.
Okay.
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 So now we have identifying gaps, positive opportunities for closures or consolidations, opportunities to reduce administrative burdens, and barriers to achieving goals.
Is this where we would also put in the language that Daisy and team came up with?
No, I think that is just going to be a new number.
Okay, of it, don't
4, 5, 6.
Okay,
I think so. Just under the general
Yeah.
heading of the plan shall.
okay.
EMS had another
Yeah.
addition here.
Streamlining methods of data entry and clinical information sharing along into that administrative burden.
Number B. And then they added a D.
Is this the point in time?
Let's get it. Just the blueprint piece. 2 reports, not just the primary care spend, but a separate blueprint.
So as we're looking at VMS's suggestion, and I'd like to add that the administrative burden piece B, their suggestions on that. Does anyone have a problem with adding their suggestions on other types of administrative burdens? Where are they? They are,
So I think the only thing I might just want to chat with Jess a little bit on the language, because things that are in there right now are the burdens and streamlining. It's not a burden, streamlining is the solution. So, I don't know, so maybe we can come up with another word there.
okay, so we'll work on language with that. And then they have a suggestion for a D. Is this where I get 15 minutes before the floor, I get to tell you what I am really hoping for in this bill?
I guess it is.
No, I don't get to do what I want because everybody, but we have talked on and on and on about primary care. We value them, we say we value them, and then we just discount everything that they do, everything that they say. Frankly, it's frustrating. And Mari, they need some sharp teeth. And I would like, if we are doing this in this, if we are taking the steps in this bill, I want to create some sort of commission on primary care. And I want them to have not just in consultation with, or, you know, with advice from the usual, yeah, sure, we'll take that under advisement, but I want them to have a seat at the table, and I'd like that seat to be have some authority with it. Yes, Lori.
So how is that different from all the testimony we heard about using the primary care subcommittee as the Green Mountain Care Board? Why are we creating a whole new group?
Why don't,
I mean, not that I agree with your point, but it's more money,
could we take the existing primary care advisory group and turn them into a subcommittee that actually has a seat at the table in various things? I'm kind of looking to Jen.
I don't know what you mean a subcommittee of.
Well,
Not gonna be a subcommittee of the board. I mean, right now they're
are they
an advisory group, primary care advisory group. The board has the authority to create advisory groups, and they have.
Okay. So we did not create that?
No.
They were in
The
statute.
primary care one is?
Yeah, I thought they were in statute.
Like, there was one that was,
What?
Mike Fisher, I suppose the statute, but I couldn't find it.
yeah. I couldn't-
Okay. I'm sorry.
It might have been created and they might have been directed to create one in session law.
It's sort of a directive to create groups to.
Right,
inform the
there's
work.
one specific one they're supposed to have that's like a consumer and patient, you know, and provider and others that is in statute, and then the rest is they can create others. I do remember referring to them at one point in legislation several years ago, but I don't think they were actually a creation of statute.
Well, if it means starting a advisory subcommittee as recommended by Vermont Medical Society, then
I think that's the advisory committee in the advisory committee in the bill.
yes.
So you could, you know, you could formalize the primary care advisory group that's a board and, you know, call them out in statute. And then if there are specific places you want the board to consult with them, or for them to provide information to the board, we can build that all into the board statutes. If, I think it's a question of where you want it to live and who is supporting it.
Can it live within this piece of the statewide healthcare delivery? Because remember, this is not just a one and done. This is a continual, always being updated and worked on.
And so is the advisory committee. So I think you have to think about just where you want them and what they're advising. I'm not sure I'd create them
I'm
in the plan.
confused.
Joseph Barnard, Vermont Medical Society, thank you so much for taking up this issue, very near and dear to our heart. I will just give the thinking on why we propose them to be sort of embedded in this work rather than stay within the PCAG or the Green Mountain Care Board. At least to date, our experience and perception of the role of the PCAG is really to advise the Green Mountain Care Board. They are within the Green Mountain Care Board. So that means they advise on specific issues within the purview of the Green Mountain Care Board, like hospital budgets, ACO, insurance rate review. And I think one of the frustrations that the PCAG has experienced is a lot of the issues they want to bring up around prior authorization, EMR streamlining, referrals to cyclists is not really within the Green Mountain Care Board regulatory role. Those are really either legislative or AHS issues, much broader. And so it's led, in our perception, to a disconnect between the issues of interest to PCAG and their role, or really, and even Green Mountain Care Board's role. So we had suggested, since this group and plan will be much broader and looking at the whole healthcare system, that we really think primary care needs to have a central role in creating that plan. Other ways to approach it, for sure. This was just our recommendation of making sure that at least within creating this whole new plan for our vision for our healthcare system, primary care is really central and highlighted.
So, and you're envisioning this would be a part of AHS? A subcommittee
Correct.
sort of housed in AHS?
Well, as much as this committee is being housed there, because we heard the idea of a commission, but then we had the same questions of who would staff it, who would fund it. But at least this bill is already creating that structure for this committee. And so that could be an added responsibility within the committee structure.
Do you foresee any sort of appropriations that these people would require to be on this subcommittee?
That definitely occurred to me. We were asking practicing clinicians to take time away from their work. I don't know. I am not expert in how that's typically done with other commissions or volunteer sort of members of groups being established. I guess I would defer to the committee's this committee's experience with how that's been done in other.
I feel as though we have set up an awful lot of subcommittees over the years that don't.
So generally, when you have set up groups, typically you have people who are there in their professional capacity. So you have, representatives of various groups appointed by some member of that group, and they're kind of representing the position of that organization in stakeholder work. When you have people who are not being under 32 VSA 1010, people who are not otherwise compensated by their employer for their participation are generally entitled to per diem compensation and reimbursement of expenses.
Aren't essentially all of the people here are paid by their particular group, either that or it's their designee?
I think many of them are not. I mean, I think all of the providers who are being appointed by various groups would not be there in their. So as opposed to the chair of the UVM Medical Center Department of Family Medicine.
No, and you're heavings. Let me just get feelings on general sentiment. I would like to create. Is anyone opposed to this?
Can I just ask you a
Yes.
question? I'm not opposed at all. I think primary care needs to have an elevated voice in all of this. I think I got lost in, are we just taking the PCAG group? We're creating a whole new group. So my only concern there is the appropriation, not that it's not needed, but how please you can get something set up. But I do think it needs to be, I do think primary care needs to be elevated. I would like to better understand maybe why. I understand like PCAG is part of Green Mountain Care Board, but can't we put them, since it's already established, in here, at least for the portion of like having the primary care voice in this plan? Or do you think it has to be a whole new separate?
Jessica Barnard, Vermont Medical Society, we did propose having a PCAG member also serve on this committee to have a bridge between the two. I think this representation is also a little bit more formal in how we suggest it, who would be represented, where PCAG is really sort of whoever's interested can ask to be part of it. I think I can do a little more thinking. I think there will be certainly overlap and maybe would inform the future role of PCAG. And now I think, whether PCAG, it's a good question. I had not thought about, the sort of the future, would we even need PCAG? I don't want to say we don't yet until I think about that a little bit more. But I do think this would be a little more formal, a little more structured, have some formal, hopefully, goals and objectives within the more formalized plan. So I do see it as a little bit different, but I'll think about it.
We could put this list to begin with to just the people that don't require an appropriation. Mari, and then, I'm gonna, if everybody's in agreement, I'd like to work with Jen and come up with something for language, but Mari, go ahead, and then Brian, and then I think we're gonna go to the floor.
Comment, a couple comments, but first I want to begin with, I need a little bit of your time before floor because I'm confused about certificate of need bill, the way it's presented in the House calendar and so we don't have to do that now, but.
Because I didn't have calendar while you're talking.
Okay, there's just some things that are underlined as new that we already passed out of the House.
Yeah, but they're not law yet.
So that's.
It's not a markup, it's not markup, it's just showing literally what the Senate is proposing that the bills say.
So my job is to.
Can we do this off?
Yes. So my comments are, whether it's, I had the same question as Lori about whether it's a PCAG member that's formalized into having an authoritative voting position or, the commission or whatever.
Advisory.
Whatever this other group would be called, as long as it's formalized, and I'll follow your lead and Jen's about how that might happen. And I just want to throw kind of a bomb out there. We've had conversations before about this, but I would love to require that a primary care provider be one of the 5 members of the Green Mountain Care Board.
It used to be.
Yeah.
Well,
Not required.
it's not required.
Yeah, but there was one on there.
We haven't even been able to make it required that one of them has to be a doctor
For a healthcare
or a
provider.
healthcare professional. Brian, and then we're gonna go to the floor.
I support the idea of having a more empowered group of primary care providers that includes more than doctors on it, and that one of the powers and duties of that group be how to get us to a place where we guarantee primary care as a public good.
But the process is already done. Many games have already gone down.
Thank you. We can go off of live.
I don't know if